Sure.
Sir, session over to you.
Thank you. Good afternoon, doctors. Welcome to this webinar on role of Oseltamivir in flu management. This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have got 30 years of excellence and 36 state-of-art manufacturing facilities. 300 plus products in our portfolio and presence in 126 plus countries. 21,000 employees globally, and Hetero Healthcare is the largest closely held pharmaceutical company in India. We are the largest manufacturers of ARV, APIs, and FDFs in the world, and we have Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Pioneering in quality and innovation, Hetero Healthcare has distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneer in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, we have got Dr. Sridhar as moderator and Dr. Pawan Kumar and Dr. Sankoch as our speakers. Welcome, Dr. Sridhar. Welcome, Dr. Pawan Kumar, and welcome, Dr. Sankoch. Dr. Sridhar, sir, is practicing since 20 years, Professor Apollo Hospital and Medical Science and Research, Director Neo BBC Hospital, Hyderabad, Treasurer Secretary Twin City Branch 2021-22, 23-24, Joint National Coordinator CIAP 24-25 Presidential Action Plans, Secretary PATS 2025-26, Medical Legal Expert, major achievements in 7 national and international publications, Additional Chief Organizing Secretary Pedicon 2025, Organizing Secretary EPA Pedicon 2016, Pharma Trade in Charge in all conferences since 2016, Vaidya Ratna Award 2023 from BC Roy Mother Found. Welcome, Dr. Sridhar. Dr. Pawan Kumar, sir, is Professor of Pediatrics, MNR Medical College, Consultant Pediatricians Omega Clinic, Scientific Convener National Pedicon 2025, National Advisory Indian Pediatrics Journal, Fellowship in Allergy and Clinical Immunology, Postgraduate Diploma in Pediatric Nutrition, Postgraduate Diploma in Developmental Neurology. Sir has received many awards, including Bharat Gaurav Puraskar 2023, Best Pediatrician of the Year Award 2023, Vaidya Ratna Awardee 2015, OGU Outstanding Academician of the Award 2023, Dr. APJ Abdul Kalam Health and Medical Excellence Awardee 2021, COVID Warrior Award, Asia's International Researcher Award 2023, Eminent Doctors of the South India Award, Best Researcher Award 2016, 18, 22, 23 by MNR Education Trust, Dr. Y. Reddy State Gold Medal Award, and Chandrasekhar Chaudhary Gold Medal. Welcome, Dr. Pawan Kumar.
Thank you,
Dr.
sir.
Sankoch
Thank you so much,
sir, is Director Paramita Hospital for Women and Children, working as consultant pediatrician since 1989, 35 plus years of experience. Sir is President, Pediatric Association of Telangana State 2025 PATS, Treasurer Pedicon 2025, and Chairperson Pediatric Intensive Care Chapter of the Telangana State PICCKTS 2023. With this brief introduction, I hand over the session to Dr. N.L. Sridhar. Over to you, sir. I'll stop my sharing.
Thank you.
Yes.
Good afternoon, everyone. Let me just 1 second. I'll share the screen. Able to see?
Yes, sir. So you can make it in the full screen mode.
Yeah, I will just. Yeah, able to?
Yes, sir.
Yeah, that's great.
Clear.
So, very good afternoon to everyone. My esteemed
Good
panelists, I welcome Dr. Sankoch Bhaskar sir, President of PATS 2025, and also I welcome the Professor of Pediatrics from MNR Medical College, Dr. Pawan Kumar. Both are elegant speakers in their own things. And coming to today's beautiful topic and need of our role of Oseltamivir in flu management, we'll be having a brief introduction and also followed by the panel discussion and few case presentations and few questions which are having the most common doubts people are having. Those will be clarified by our esteemed panelists. So coming to the today's topic, Oseltamivir and challenges. So the first important is healthcare challenges in monsoon and their diagnosis, and influenza and its complications. It's a brief note because before going to the case discussions, what are the influenza viruses and how the incidence is there, and what are the clinical evidences of oseltamivir is there, guidelines, recommendations. These has to be definitely taught to the people who are listening today's session, because that will be helpful in their day-to-day practice, these case scenarios and questions, everything. And moreover, you know very well, the rainy season is extended in total Telangana, a few more days, or maybe 2 or 3 weeks more. And most of the influenza-like cases are seen in most of the OPDs, and there are so many, because of the severity of the infection. There are more admissions also in the hospital. So many viral infections are there, out of which few are a dengue-like and influenza-like illness, and also gastroenteritis. These are all the viral causative things. But out of these, the most is important thing is influenza-like illness. And you know very well, out of all the influenza-like illness, influenza is the father of all the influenza-like illness. So, and few more the differential diagnosis of H1N1 will be there, rhinovirus and adenovirus. We have to think of the clinical symptoms, and you know very well, the clinical acumen is the great, will be helpful for the great extent in the diagnosing this influenza, because what happens is the myalgia, weakness, headache, these are all the commonest things which will be associated in influenza illness. So we have to take a detailed history before starting the medicines. And you know very well, the diagnostics criteria are few different. One is RT-PCR, and second is flu panel test are there. Now recently BioFire module is there, which will reveal the which virus is causing the symptoms. And second thing, we have very few drugs, very few drugs. Out of one previously, the since 4 5 years, this pre-COVID and post-COVID, they started Oseltamivir, where beautiful response was given for the if the patient was started earlier Oseltamivir, there was a improvement in clinical scenarios, and child was discharged early. Child was improved very early. So coming to the next slide, why we should know about the influenza illness? Because what happens is in India, day by day, the cases are increasing. The people should know about influenza, what are the vaccines are available, what are the treatment modalities are available, and which season. Basically, 12 months is there in 1 year. Is it really 12 months the child will be affected with influenza? No. The few months are there where it will be the children will be affected more, and which is the correct time to vaccinate. These are the three important questions where we have to answer for the listening doctors. And in Indian data, we know very well 5 to 10% of the all acute respiratory tract infections are due to the influenza virus, and 10 out of 100 children 8 years suffering from influenza. And these statistics, you know very well, influenza associated acute respiratory tract infections 30 to 34% in 1,000 children per year. And in 2019 up to March, there are 30,000 plus positive, and 1809 died because of this influenza virus. And this is the graph taken from the Purple Book of Vaccination, released by our Central IIP and Vaccinology Department. And here you can see from January to April, the first peak is there. And the second, when the rainy season starts, July to September, October, the second peak is there. So whenever the peak is there, only first 3 months, and in the between, in mid for the 3 months. So we have to be careful in these two climate conditions and two things, so that we can vaccinate before. Like if you vaccinate in May, April, May, the child will be benefited. The child may not be getting the infection of July to September peak. And if you vaccinate in November, December, child may be benefited for the January, March peak. So this is the best time to vaccinate the children. And moreover, anytime child, if that doesn't have infection also, we have to vaccinate anytime in 365 days. And this is the second Again, this is from Purple Book. And Global Burden of Diseases from 2017. These are the number of cases. Hospitalizations are done 5,88,000 children, and deaths 26,000 deaths. And this is the simple how much mortality is there, how much morbidity is there. I want to tell you this much burden of deaths are there in the children in 2017. So we have to, in order to cut down the deaths and morbidity and mortality, we have to take a beautiful step where the drugs are available now in the market, so that early start the medicine, early benefit for the patient. So there is a statistical data where 22 in 20. I am not reading all the year wise, but recent in 2022 there are number of registered cases at 12,881. There are deaths 399. So this is again from the Purple Book. The pattern of circulating strain in India varies. See, in northern India, peak it will be January to March, central India, July to September, and southern India, September to November. Winter and monsoon peaks are very common, which peak occurs in these two seasons. And dynamics, there was a cumulative study in 7 years in Tamil Nadu, where study is done in Department of Virology in 2019 in King Institute of Preventive Medicine and Research, and 36,000 samples or specimens are collected, and duration of study is 7 years. And here in this study, they revealed that influenza positivity started with the onset of monsoon and peaks during the peak post-monsoon months. So the thing is, the influenza positivity is there in these two peaks. So that's the reason why this study is a beautiful, which has shown the dynamics of the occurrence of influenza. And the most important thing is here, the thing is, we have differential diagnosis. We have to keep in mind any disease, we should have a differential diagnosis. So the presentation will be similar. Influenza like illness will be presenting like influenza, but you should be able to differentiate which is the influenza virus or influenza like illness. And severe acute respiratory illness, the severity will be there and few breathlessness will be there. These should be keep in mind. And since COVID-19, we all suffered for 2 years. So that's why we kept this COVID-19 also, where the other systems will be involved. Multi-system involvement will be there in the COVID-19. Loss of smell, loss of taste, and also gastroenteritis-like symptoms. Those will be there along with the COVID-19. But the important thing is H1N1, where we should be able to differentiate clinically the case and start that, because any investigation, it will take 24 hours to 48 hours. The report should come for the PCR or other investigations. So in meantime, better to start the medicine, better to give the improvement for the child. One second. So this is a bar diagram which has shown again the incidence of influenza and related deaths. I will not go into depth. Case of influenza infection and deaths due to. So in the thing is 28,798 cases registered and 18 deaths are seen in the this blue color is 2019. So a brief note on influenza A and influenza B and influenza types of influenza virus. Most frequent is influenza A epidemics, but influenza B virus infects only humans and cause local epidemics. And whereas influenza C, it infects humans and swine, that not thought to be cause epidemics. So these influenza A is most important, and few cases we have seen, you are going to see in the case presentations where influenza B is also diagnosed in one of the cases. So concurrently circulating in humans are subtypes. Common is H1N1 and H3N2. These two are the subtypes which are commonly existing in the humans. And you know very well, transmission of flu virus because of the droplet infection. I will not go into deep. Because of the sneeze and talk and flu and cough, the droplets will be released and inhaled into the lungs, and these will be infected. So you should be taking the most healthy adults may be able to infect other people beginning 1 day before the symptoms develop and up to 5 to 7 days after becoming sick. So there are few differential point symptoms on where we can diagnose is the H1N1 or influenza-like illness or severe acute respiratory infections. One is most important is breathlessness. Breathlessness is not that much common in influenza-like illness, but it will be there in H1N1 infection, influenza infection, and also in severe acute respiratory infections. And one thing, the associated, what I said in beginning, myalgia, headache, and body pains. These will be there in weakness, will be there more in H1N1 influenza infection, and also in COVID, as I said, multi-systemic involvement. And there are benefits of empiric and early use of oseltamivir in clinical trials. It had decreased the antibiotic usage and also influenza-related lower respiratory tract complex infections resulting in antibiotic therapy by 55% reduction, and hospitalizations reduction is there by 59%. Remember that the antibiotic usage has decreased and hospitalization of the patient has decreased. These two keep in mind if you start the oseltamivir treatment in influenza illness. So, you know very well my experience with Oseltamivir. I will not wait for the panel, this flu panel test and RT-PCR, because our flu panel test will take 48 hours and RT-PCR may take more than 24 hours. So we do start in the severity is there, child is dull, and I do start in these epidemics. We started Oseltamivir, and there was a beautiful response in the children. And now it's the time for my panelists to jump in into the things and start. Mr. Pavan, let me call
Yes,
on
sir.
Pavan to start the first case so that throw light
Yes,
on
sir.
how the diagnosis, how the presentation will be there, how the modality treatment is there. Please, Pavan, please go ahead.
First of all, special thanks to Dr. Sridhar sir, Dr. Sunkod sir, and Dr. Prashant sir, and Dr. Samruddhi for giving us this opportunity for interacting with my junior colleagues and our own pediatric fraternity. Thank you so much, sir. So now coming to the case, this is a real practical case scenario which we see in day in and day out. A 4-year-old boy, Rajesh, who is admitted with a history of fever for last 6 days, along with cough and cold since 5 days. So this is a common scenario, especially when the season is there. Like I think pediatricians last 1 month, 1.5 months, we are seeing a lot of cases with the same complaints, right? Hope you all agree with that. And if we can see this child is having a respiratory rate of 45 per minute, which is definitely high for that age. So the child is tachypneic with irritability. And upon auscultation, this child has these bilateral crepitations. Otherwise, this child is well thrived and his weight is also 15 kgs, which is expected for that age. And now the question comes, how do we proceed? This is the common case scenario, but how do we proceed? And what should be the initial management? What are the basic investigations we need to do in this case? And do we start antibiotics on the day of admission? If so, which antibiotic? These are the common questions every pediatrician usually we get. So how do we proceed? Always please remember, admit the child whenever you feel that the child is sick, especially is not able to sleep properly, is not able to eat or drink properly. Please don't hesitate to admit the child. For the benefit of doubt, I've seen some kids have become deteriorated very fast. And please start oxygen. Oxygen is a wonder drug. That is the first drug of choice which we need to start whenever the child is having respiratory distress with we need to almost we need to monitor the saturations also. And don't forget to start oxygen in a non-threatening manner. This is very important to understand. Why means a child who is crying a lot, his oxygen levels automatically goes down. He will not be comfortable when somebody is putting something on his nose and all. So always try to give oxygen in a non-threatening manner. That is the most important aspect here. Everybody should understand. Always allow the mother to stay with the baby, because any stranger, especially we are seeing these cases, these children are getting admitted into the ICUs if they are less than 1 year infants. More than 1 year children, they are not that sick, but they are admitted into the wards. But they are really cranky and irritable. So we need to start oxygen in a non-threatening manner whenever there is a RD. And always give the supportive care is the most important thing for any viral infection, because the child will not be able to eat anything or drink anything. We need to start him on IV fluids and do basic investigations. So the basic investigations in our OPDs are definitely chest X-ray. We need to do it because the parents will be, any parent will be very panicky seeing the child having a breathlessness and chest retractions and all. They themselves will ask us to go for an X-ray. So that is only not to confirm anything, but to rule out the other secondary bacterial infections like pneumonia and all. CPP is one thing which will help us very critically in our routine practice. So if you see there is a lymphocyte predominance with a neutropenia, so and there is a CRP is also negative. So that will give you that you are dealing with more likely to be a viral infection than a bacterial infection. So these simple things in CBP will give you a lot of clues. Please don't hesitate to get this test done. And these days, I'm sure that short viral panel is available, which costs not more than 3,600. We are going to get the result in within 24 hours. Because once you have a confirmation that influenza A positive or influenza B positive, then you don't need to start any antibiotic actually. But here, in this child, we need to start antibiotics based on the IMNCI guidelines. We started with the basic antibiotic like amoxicillin, just to prevent any secondary bacterial infections. So here in this X-ray, you can see the child has a normal CBP, and chest X-ray is also showing bilateral interstitial infiltrate. This is what you can see in every X-ray in this season especially. And viral panel has come out to be positive for H3N2, which was positive for influenza A for this child. But I'm telling you, dear friends, 68% in this season, it was H1N1. The same virus which has resulted in the resurgence of this 2009 pandemic, which has claimed so many lives at that time. So, and compared to 2004, we can see there is a 23% increase in the number of H1N1 cases this year, 23% compared to 24-25. Even we didn't complete the year, but still there is a surge of 23%. And immediately then next question is, does this case require antiviral drug, and which drug is important here? I'm telling you, dear friends, this we are going to have this life-saving, we are going to see the life-saving potential of this antiviral intervention, which is nothing but Oseltamivir. So, which is, I'm going to discuss that. But if you start this antiviral drug within 48 hours of symptoms, and please remember, it works like magic, and the cough, which was very bad, and one clue in the history, which will help you to differentiate between flu and other viruses, are if the child is coughing day and night equal in intensity and severity, please consider it as a flu. Don't hesitate to start antiviral. Don't never hesitate to start, because that will also protect you from giving an antibiotic, which is ineffective against the virus. We all know it's like opening our home door with the neighbor's key. It will never work, right? So we have our own key, so we need to use the correct medicine. So always use antiviral when you get the confirmation. Please remember the dose. This is very important. We need to understand 3 mg per kg per dose. Luckily, fortunately, Hetero has brought it in a oral formulation, the syrup formulation, which is very important for pediatricians, because the tablet and all, it's very difficult to break, and all the capsule comes, it's very difficult. So thanks to Hetero people for getting that in a syrup formulation. And it should be given twice daily for 5 days. And this is the most effective in this case. The child dramatically improved with that. And what is most important, and we need to warn the parents, especially because if they come on day 1, day 2, we need to write these red flag signs. So please tell the parents, if the child is breathing very fast and the bluish coloration of the tips and lips and all tips of fingers and the lips, and the child is not at all drinking enough fluids, and the child is not waking up, very drowsy, sleepy child, please remember that child should be kept in the hospital for sure. And if the child is very much irritable, doesn't want to be held, that is the clue that the child needs a proper admission. So flu-like symptoms improve, but the return of fever and the worsening of cough, this is what we are seeing. That is what making us to keep the child in the hospital. And some of the other things, the child is not able to eat, has a trouble breathing, has no tears when crying, because that shows the child is not drinking well and is in dehydration and all, and significantly fewer wet diapers because of dehydration. So these are some of the things we need to, as a pediatricians, we should counsel parents, ensure that they are well understood these things, and they will rush back to you immediately in case such symptoms comes. Next slide, sir. So the complications, we all know, any viral, it can cause pneumonia. It can, from simple pneumonia, bronchitis to, it can really cause death also in the children. Luckily, we are not in pediatrics. So far, I think this year in India, there are only 340 flu deaths, which has been documented out of 12,000 hospitalization. So, but there are 2.8 million confirmed cases this year. So you can see how many cases they will go into death and all. Luckily, in India, we don't have that problem. But in the Western world, they will be literally shit scary listening to the word is flu, because it has claimed more deaths there. So that's why they are very pertinent in taking vaccination also there. Next slide, sir. So treatment is very, very important. It is largely supportive, definitely, but the child should be well rested and he should have this increased fluid consumption. This is what we need to emphasize because nowadays there is a lot of restrictions and a lot of cases we are seeing on the cough suppressants and all cough drugs. So we have to increase their hydration status very well. And if the child is suffering with fever, definitely the paracetamol should be the first drug of choice. And if there is a body pains, child is very cranky and irritable, you can sometimes use NSAIDs as needed. Please remember, it should not be the drug of choice, but as needed, you can use that NSAIDs. And please remember, most patients with influenza recover in 3 days, and sometimes the malaise may persist for weeks. That is what we are seeing. But if you well hydrated child, well fed child, and much prior, much before only if you start the medication, these children, sir, they are recovering very fast without any much trauma there. So this is very important to understand. Please understand there is a game-changing antiviral which we have, Oseltamivir. Please make use of it and save the children. And these are two types of antiviral drugs which we have seen. This is very interesting actually to study the mechanism how this Oseltamivir, the neuraminidase inhibitor, how it controls. This is very interesting to study. I am telling you. I will tell you on the next slide. So there are two types. Please remember there are two antiviral drugs. One is neuraminidase inhibitors. One is adamantins. So what is the problem with adamantine is it works only with influenza A. But neuraminidase inhibitor like oseltamivir, it works against both influenza A and B, which are more prevalent in India. So how does it act? Please see. The mechanism is very important. So yeah, next slide, sir. I'll just show that slide. Yeah, this is very important. The mechanism of action, everybody should understand. It's like, terrorists have come from the Pakistan and they have been trained in our country. But when they are about to execute their plan, it was the door, the lock, they were locked inside the room. So they are not allowed to come out of that room. So similarly, viral entry happens, influenza virus enters the host cells and it replicates its genetic material and produces a new virus particles inside the infected respiratory cells. So once the infected respiratory cell is studded with these new virions, what happens is the neuraminidase protein on the virus surface, so that cleaves the sialic acid bonds, so which allows the newly formed viral particles, the terrorist gang which has been trained in the camp, so they are supposed to come out, right? But what happens is oseltamivir inhibits, it competitively binds to the neuraminidase active site, it blocks the enzyme's function and it prevents the virus release from the host cells. So no entry from POK, no terrorist is going to enter. We have sealed the entry point. So that is how this works very nicely. And what happens is because of that, it reduces the viral spread. Trapped viral particles cannot infect the neighboring cells and it limits the viral replication and reduces the symptom severity and also transmission to others. This is what is very important to understand. In the below slide, you can see that. So it halts the virus replication and also the release. So this is very important. So today we have a very wonderful drug which works like a magic. If the child coughs continuously with day and night with a severe intensity, equal intensity, please suggest use of this oseltamivir, which is a potent and selective inhibitor of neuraminidase enzyme, which is most effective against influenza virus A and B. So these are some of the pathophysiology of that, how it works and all. So it inhibits, please remember, it inhibits the influenza virus replication and pathogenicity. So it will reduce the entry into the country itself. Okay. So this is effective against all strains of influenza A and B, including the swine flu and all. Next slide, sir. Yeah, this is the first oral neuraminidase inhibitor and it is approved in the more than 100 countries. There is no, fear of using it. Please use it very safely, very safe drug with a proven efficacy and established safety profile. So there are no other drug which is so effective as this. So now over to Sridhar, sir.
Yeah, thank you, Pawan. It's a nice, beautiful case presentation. H3N2 and also influenza A type was diagnosed in this case, and oseltamivir started, and child was improved with them. And in this, the mechanism of action, oseltamivir, everything was dead because this is more important. The virions which are released, will act on the normal cell and it will be infected. But when you use this oseltamivir, it stops the virion release and the new cells will not be, healthy cells will not be infected. This is the message for the mechanism of action of the oseltamivir. And next case presentation will be Dr. Sungoj Bhaskar sir. Please, sir.
Thank you, Dr. Sridhar. I really appreciate the hetero family for coming out this very useful and relevant topic for the pediatricians, particularly during the season of monsoon. So this case, it's a 6-year-old girl came with fever and rhinorrhea since last 6 days and cough for 3 days. So, and this girl is a known case of bronchial asthma, but on irregular treatment. So nowadays we are seeing many cases of fever, rhinorrhea, sometimes cough, body pains, malaise. So immediately we think of this seasonal viral fevers. So we thought it's viral fever. But here the point is this child is an asthmatic on irregular treatment. So this is the rider here where we need to think something more about it. So when we examined the child, there were bouts of cough with no fever, but on auscultation there were bilateral crepitations along with mild wheeze present. So we know this wheeze was because of this asthma and as well secretions, as well bronchomuscular spasm. And crepitations are due to the lung secretions. So should we suspect flu infection in this child or not? So what is the criteria? So as there is a past history, see, is it a simple post-viral asthma which requires only asthmatic treatment but not antivirals? So as I told you, now the season is going on and child presented with fever, rhinorrhea and cough. In asthma, if it is just asthma, we don't see fever. So definitely we should suspect viral infection. That too, season is going on. It's influenza type A infections are commonly seen, of course, along with the B influenza. So the criteria is abrupt onset of fever, rhinorrhea, body pains, cough. So we should suspect that it's a viral infection. Since this girl is an asthmatic, it will, by itself, it causes inflammation of the airways. And also this child is an asthmatic having airway inflammatory disorder. So things will get worsened here. So as I told you, any virus, particularly influenza viruses, can trigger asthma. And it can cause even asthma flare-ups, the high chance of secondary infections as well. And this happened in our own hospital. An asthmatic child with viral fever got admitted, fever had subsided, cough had subsided, but tachypnea, retractions, wheeze were persisting for days together. And with great difficulty, it had subsided gradually with all the required measures. So what the message is, these viruses can worsen the pre-existing illness here in child asthma. So we need to be very careful whenever any child, any asthmatic child gets viral infections, it can worsen the things. So all the asthmatics, our advice to all the asthmatics is they should have vaccination every year. Annual vaccination is mandatory for them to prevent these complications. Yes, sir. Next. So what are the recommendations by World Health Organization? So let us be rational, but sometimes we need to be empirical as well. So when season is going on, when you're suspecting influenza virus infection, please initiate the empirical treatment, that too with an effective antiviral drug, which is fortunately evidently available now. So we need to start, and we should not wait until we get this RT-PCR reports. And as well, we should start the treatment as well. As Dr. Pawan Kumar said, the treatment in all these viral respiratory infections, basically well hydration, oxygen, oxygen, and oxygen. This is going to give great relief to the children who are having this breathlessness. So oxygen, IV fluids, all the supportive measures should be started as early as possible. And simultaneously, we can send the blood samples for RT-PCR to confirm whether it's influenza A or influenza B, or nowadays we are seeing RSV as well. But anyway, there is a lacuna. If this test comes out as a negative, does not exclude the diagnosis, because there are always a false negative and some false positive reports are seen. And high risk individuals, as just now you were discussing, asthmatics, immunosuppressed, when they are exposed to patients with influenza, we should consider oseltamivir as a prophylactic drug in these children. Next slide, Sridhar. So let us give empirically antimicrobials, particularly antiviral, and as well, if you want to use, again, it's left to the discretion of the clinician to add an antibiotic to treat all likely pathogens causing severe acute respiratory infections. And again, the empirical antibiotic should be based on whether it is a community-acquired pneumonia or is it a healthcare-associated pneumonia. Based on that, we need to choose the antibiotic. Whereas for viral infections, the empirical therapy, it includes a neuraminidase inhibitor, which is abundantly available, as I told you, for influenza A and B when there is a local circulation, or any child having viral fever with other risk factors, we should start this neuraminidase inhibitor even in our OP settings. Next, please. Sridhar?
Yeah, sir, changes.
Yeah.
Yeah, change it, sir.
So in adults again, in adults with the community-acquired pneumonia who test positive for influenza, should we include antiviral therapy? It's always a question, because they say for a healthy children or healthy adults, we need to think twice before we start antiviral medicines. But any adult with some pre-existing illnesses or some immunodeficiencies, we should start empirically the antiviral medicines. So what we recommend is, we recommend oseltamivir be prescribed for adults with community-acquired pneumonia who test for influenza in the inpatient setting. So when I say inpatient, the adult is not in a stable condition. So there we need to start. And also, if the duration is less before we diagnose and initiate, the outcome will be very good. And treatment within 2 days of symptoms with oseltamivir may result in the best outcomes. Sridhar.
Yeah.
Next, please.
Yes, sir. Nice. Next.
It's not moving. So in this
Sir,
child, yeah, now it's visible.
Yeah.
So any child who is coming with fever, breathlessness, or tachypnea, we should take chest X-ray. It's not mandatory, but it's preferred to have a chest X-ray. Here in this child, the chest X-ray was showing increased bronchovascular markings, that is interstitial infiltrates, and as well hyperinflated lungs, because the child is an asthmatic and as well having this viral infection, respiratory viral infection. Complete blood picture as expected, it's normal. We sent for viral panel. It came after few hours, wherein it was AH3N2, and the child was given oseltamivir along with other supportive measures and as well asthma treatment. And once fever controlled and the breathlessness, tachypnea has come down, and the child was maintaining SpO2 in room air around 97-98%, we had discharged this child and advised the uh, correct asthma therapy, that is inhalation therapy.
Sir.
Okay, thank you.
Thank you, sir. This is why we kept this case means the comorbid conditions are there here. The child is suffering with asthma, and where the influenza will flare up the asthma and causing more bronchoconstriction. That's why the treatment should be very much balanced. We have to keep in mind the asthma child and also the present infection, which is causing flaring up of the asthma. So here the doctor had treated balancedly this case with oseltamivir and also asthma therapy, where the child was improved with this oseltamivir very fast, and so the child was discharged on steroid meter drug inhalation, and child was very much better. So here the message is the comorbid condition asthma is there in this case. So you should treat both the cases. It's not the because of the asthma child is having respiratory distress and tachypnea and other things, but you should keep in mind the myalgia and everything, fever, because fever will not be there, not that much common in asthma. So we have to keep in mind before the diagnosis the case scenario. Again, I want to remind you, clinical examination will reveal all the positive things, and you can diagnose this. So next case, I request Pawan to start.
Thank you, sir. Yes, sir. So this is another common case, dear friends. The 2-year-old boy who is admitted with high-grade fever for 2 days, along with cough and cold for 2 days, and the child is having breathlessness. Please remember, in the season of flu, any child who comes with breathlessness, cough, cold, and high-grade fever, don't hesitate to think it as a, keep your differential diagnosis as a top as a flu, because the entire city is full of flu cases. And when the child comes like that, please ensure that you have keep it as a top number one. And here the child is restless, irritable, and with a respiratory rate of 60 per minute. A 2-year-old child with 60 per minute, we definitely is tachypnea, and the fever is not less than 103. And what should be our initial management here? And do we need to start preemptive anti-flu therapy with oseltamivir? What is the criteria? That is what we are going to see here in this case. So the initial management, like before, the child is having respiratory distress. We need to start him on oxygen in a non-threatening manner and start with IV fluids to support for a well hydration. And if needed, please don't hesitate to give ventilatory support. I'm sure this season, we have started the children who are admitted in NICU, the ICUs, we have started them on high frequency, this HFNC. So that nasal cannulation with oxygen has really changed, a dramatic change. The child who is supposed to improve in 3 to 4 days, the child here improved within 2 days only. So HFNC is one such factor. Non-invasive ventilation has really helped the children to come out very fast. Yes, any role of presumptive antibiotics? Definitely, because if it is a confirmed case of viral, definitely there is no role of antibiotics. But here in this case, we can start with, because the child is very sick with high-grade fevers. Let us start with, as per the IMNCI guidelines or the hospital policy of to start an antibiotic is there. Please start that. We can discontinue later. But here, don't hesitate to start antibiotic in the current scenario. And do we want to start a preemptive anti-flu therapy? What is the criteria? Just we will see in the next slide. So the antiviral treatment of influenza, because the criteria for successful treatment is early initiation of the drug. So don't hesitate whenever you see a suspected influenza-like illness. When more than one person in the family is suffering from similar complaints, please think of that is a flu case, viral case only, most likely to be flu. Confirmed influenza with a report coming as a positive as influenza A, B, or H1N1, something like that is there, documented one. Please don't hesitate to start oseltamivir and have the underlying condition. This condition is very important. Please understand. The children who are asthmatics, like discussed with Sunkoji Bhaskar sir has nicely discussed that case in the asthma. But similarly, there are other conditions where they are more prone to get the complications of influenza, like nephrotic syndrome, immunosuppressive children are, antiviral drug, HIV, and all those things. These children are more susceptible for that. So don't hesitate to start antiviral in them. And please don't ensure that, it should be initiated as soon as possible, regardless of the duration of illness. Always it is important to start as early as possible. There is an interesting study done in the AIMS, where there are 842 patients were studied, in which they have seen there is a 62% reduction in the hospitalization rates when oseltamivir started within 36 hours of symptom onset. Because our idea was to give only supportive care, because we suspect viral, but they have studied one group as a supportive care only, and other children they have started oseltamivir. And what they found was there is a 62% reduction in the hospitalization in this group. So that gives us emphasis that each and every person has to start oseltamivir as early as possible. And there is a study, interesting study in Kerala also, which they have shown that 48% reduction in the ICU admission and mechanical ventilation requirement has gone down by 53%. And also, this is a very common observation, also studied, proven by study, thus it has shortened the fever duration by 1.7 days, and it has reduced the secondary bacterial pneumonia risk by 38%. So what does that mean? That will also reduce the antibiotic resistance, antibiotic usage also has been come down. So this child, we can see in the X-ray, there are bilateral interstitial infiltrates were there, which are sign of for this viral infection. And CBP has given a very nice clue here. Whenever you see a picture like this with a bilateral interstitial infiltrate, please think of it's a flu only, influenza. Okay, so here the child in the short viral panel, which we routinely do in our hospital, the children with respiratory distress. So it has come H3N2 positive. And let us see the dosage guidelines. Please keep a card of dosage guidelines. I think Hetero is happy to give that card with you, because it is really helpful to prescribe the drug in a correct dosage. In adults, because it's not only the child, right? Entire family will get infected. One person is infected means it is as Sridhar sir clearly mentioned, even with the 6 feet distance, you can transmit, the person can transmit to the other person because of, droplet spread and all. So, and children are more likely to spread this. And as sir clearly told, one day before, because the parents, they get that virus from outside, parent may not be having symptoms, but one day before only the parent can most likely to transfer the virus to the child. And till almost 5 to 7 days later also he can continue to transmit. So always tell the parents to wear a mask, that to N95 mask, because that will definitely prevent, and hand washing and sanitization is really helped us a lot. And that guidance we have to tell the parents also, and we can also guide them. There is a treatment for adults also. 75 milligram capsule is available from Hetero only. I think can give twice daily as a treatment. But please remember, when it comes to prophylaxis, it should be once a day dosage, and that to 75 mg capsule for adults. But for children, please remember 3 mg per kg twice daily in the treatment part, and once a daily only for the chemoprophylaxis part. There are different weight brackets you can see, and what is the dose with ml? It has been nicely mentioned here. Thank you, Sridhar sir. I think this should be taken screenshot and kept in their clinic OPD, sir. Next slide. So the same child, here is an interesting thing. This child who is admitted in our hospital, he has an elder sibling who is a 5-year-old with a nephrotic syndrome on steroid therapy. He is already on steroid therapy. Then the parent asked, what is the risk for him? Can this child also get the virus? And do we recommend any preventive therapy for that child? This is the common question. No, parents will ask you, we have another child at home. He will also most likely to get, because mother is also suffering, father is also suffering, and this child, only that child is not suffering. So please remember, any high risk child, usually less than 5 years, they are high risk only. But here we can see the nephrotic syndrome child who is on steroids, and there is no role of vaccination immediately, because the child who is on steroids, we don't give vaccine, right? So he should receive prophylactic. The only option left for that child is Oseltamivir, the antiviral drug, which we need to give as a prophylactic dosage. And I told you it is the same dose. Please remember, 3 mg per kg per day. But here we don't give it twice daily, but here we will give it once daily for 10 days. That is the duration also, please remember. So next slide, sir. So when we can give antiviral treatment in the OP setting, this slide summarizes that any high-risk condition that predispose them to complications of influenza. Because as you know, immunocompromised child, they have more likely to get the complication. Even some children, they may die also because of this influenza. And the children younger than 6 months, please don't hesitate to start prophylactic therapy. And antiviral treatment may also be considered for children with suspected or confirmed influenza disease whose siblings or household contacts have the disease. And for symptomatic therapy, we will definitely do for symptomatic children. But the preventive antiviral therapy should be given as an adjunct to vaccination in certain individuals, and those who have this high risk, who are not expected to mount an effective immune response because of their low immunity levels. So those children has to be given that.
Yeah. So nice case presentation. Here the important thing is the child is who is having the respiratory illness, influenza. The sibling is having a nephrotic syndrome. So here the comorbid conditions of the sibling has to be taken into consideration. That's why the guidelines of antiviral therapy, when to start. If you suspect a case, or if the child is proven case, we have to start this Oseltamivir oral antiviral drug. And second thing is, if the sibling is there on the treatment on steroid, we shouldn't give the vaccine for this flu vaccine shouldn't be given after 2 months, 6 weeks to 8 weeks. We can give the vaccine. And second important take-home message point is in this is the child should be given if you suspect. If the child sibling is having, you have to prophylactically give the dose, single day dose for 10 days for the nephrotic syndrome child sibling also. So this is the message what has to be given here. And next case, the case 4 by Sungoj Bhaskar sir. Please, sir.
This is another interesting case. A 12 years old girl was admitted with fever and joint pains since last 4 days, along with mild cough for 2 days. So during this season, 12 years old girl coming with fever and cough, naturally we suspect some viral respiratory infection. But the same girl has joint pains as well. So again, we have to think in terms of any other connective tissue disorders. So she's not a known case of chronic lung disease. And on examination, child was restless with cough and low fever. And on examination, mild arthritis present. It's not very significant, but it's tender and slightly warm. On auscultation, bilateral crepitations were there. So should we suspect any associated connective tissue disorder with flu case? Does it alter the disease course? So 12 years old girl presenting with fever and arthritis, we can also think in terms of any autoimmune disorder. Since season is going on, we first tend to think of viral respiratory infections. So what we did, then we did CBP. Fortunately, it is normal. No increase in neutrophils or no increase in even in neutrophils. Then we took this chest X-ray. Again, we could see mild bilateral interstitial infiltrates, and anti-nuclear antibody profile was normal. So that, to some extent, we could keep this autoimmune disorders aside for the time being. Then the viral profile was done, and it had shown this influenza type B. And next we proceeded. So here, so we know that any viral infection, particularly influenza virus infection, can trigger or aggravate this interstitial lung disease in a girl having this pre-existing illness. It can either trigger or it can worsen in those who have this underlying connective tissue disorders. We do know that frequent viral infections might play a role in development and progression of connective tissue disorders, particularly chronic lung disease, that is interstitial lung disease. And all these patients, that's why, particularly those patients who have this chronic lung infection or interstitial lung disease, they should have annual vaccinations without fail. And whenever there is a sign of viral pneumonia, we need to start Oseltamivir, as we did in this case, early in routine doses. Though this child came after 4 days, still we had used this Oseltamivir because it has some benefit even if you start after 48 hours. So any change of clinical picture, medication and management. So how to differentiate clinically between influenza type A and type B? It's not always easy. It's really difficult to differentiate between influenza A and influenza B clinically. But influenza A is more severe in children and as well in adults, whereas influenza B is more severe in children below 5 years. It's not that severe in adults because by the time they have this, they develop immunity against this virus. And the complications like pneumonia is more in influenza A, and it is the same even in influenza B. Mutations are more with influenza A, whereas mutations are very less or uncommon in influenza B. Therefore, we see a lot of new strains each and every year, and that's why the composition of the vaccines do change as and when they are required. Whereas this problem is not there with the influenza B. Influenza A is known for evolution, so-called this antigenic shift and antigenic drift. Influenza A can infect even other animal species. Hence, the chance of spread is more. And ideally, still, we do recommend quadrivalent vaccine, which includes both A and B, though Yamagata is not seen, but better to have quadrivalent vaccine because future it might come up or it might flare up. For that reason, better we use quadrivalent vaccine. So, how to prevent these viral infections, respiratory viral infections? See, pharmacological and non-pharmacological. Non-pharmacological, we are very much blessing in disguises. We are thankful to the pandemic 2019, where we learned more about this hygiene, like hand hygiene. The best thing, not only for this, for any other infections, the the what you call the culprit is our hands and our mobile phones. So try to wash your hands frequently with soap and water. And when there is no soap or in between, you can use alcohol-based hand rubs, sanitizers. And in when you while moving socially, whenever you cough or sneeze, try to put tissue or a handkerchief or at least your sleeve against your mouth, not to so as not to spread the organisms to others. And also, we do have this can spread through fomites. So you need to clean your mobiles, you need to clean the table surfaces in order to prevent this fomite through spread of the virus through fomite. The pharmacological intervention, we should have vaccination annually, particularly in children below 8 years, and as well people who are above 60 years, and special groups like we, healthcare professionals, those who deal with animals, and ideally every person should have vaccination if possible. And fortunately, we have this neuraminidase inhibitor, oseltamivir. It can be used prophylactically, as we had seen in two cases here. Those who have this pre-existing illness like asthma, again, then we have this nephrotic syndrome. Not only that, in many other cases, we can use it as a prophylactic medicine. These are the preventive measures we should adopt.
Thank you. Thank you, sir. So here this fourth case, why important means first age factor 12 years. Second thing, child is having joint pains along with the respiratory tract infection. So the clinician made to think about why the joint pains, arthritis, commonly these presentation in that age group. We have to think of any connective tissue disorder, but luckily the anemia profile is negative. So it was proven as H1N1 and influenza B. Here the case diagnosis is viral panel has shown influenza B. So common is influenza A, but here the case presentation is influenza B. That's the made the importance to present in this case. Why? What is it? There is any difference clinical scenario? No, there is no clinical scenario difference between influenza A and B. Management? No. Only the existence and severity, as Sir said, drift and shift is common in this mutant genes. Why this mutant will be more in influenza A? That's why we have to keep in mind influenza A can cause more pandemics and also more vulnerable to mutation, this genetic shift and drift. So we have to keep it. That's why this case was presented. And you know very well, hand hygiene keeps the first in the treatment part. And pharmacologically, in this case, if the child is really connective tissue disorder, and healthcare professionals definitely has to receive the vaccination annually, and prophylactic oseltamivir has to be given in this case. So till now we have gone through case presentations. Now the common questionnaire where the most of the patients parents will be having doubts and doctors will be having doubts. The first question is to Sunkoj Bhaskar sir. Has the incidence of viral infections increased? What could be the possible reasons, sir? Bhaskar sir. Hello.
Yeah. Thank you, Dr. Sridhar. This you are already shown in one of your
Yes.
slides. The incidence of viral infections are dramatically increasing. There are multiple reasons for this complex problem. And the reasons are, if you see carefully, there are three reasons. One is human created reasons, and the second is environmental reasons, and the third is viral. So, what are the human causes for this increasing incidence of viral infections? It is we are encroaching on the animal habitats. That is, we are doing deforestation. We are going into the forest. We are displacing the microbes, and they are becoming closer and nearby human beings. So we are having a lot of zoonotic disease because of this. And secondly, the population density is increasing. Thirdly, there is intensified global travel. People are traveling across the globe. Today, he is a person if he is in US, tomorrow he may be in Brazil or in Tokyo or in Delhi. So the rapid global travel is also carrying these different viruses to the different
Yes.
places. And the
Yes.
most important in developing countries is deficiencies in public health services, public health measures, like lack of proper sanitation, the lack of clean water supply. So all these are leading to this incidence of viral infections, which are increasing. And
Okay.
secondly, this the viral viruses are so smart. Again, the due to this uh, variants, due to these mutations, as you said, the antigenic drift. These viruses, they are changing their structures. They are what you call the vaccines are not against them unless you change the vaccine based on the circulating virus. So the viruses are spreading rapidly and they are becoming more smarter. So there are multiple reasons for increasing this incidence of viral infections.
Yes, sir. One more point is to add to this malnutrition, sir, because most of the patients
Yeah,
will be
exactly.
children will be malnourished. So the incidence of viral infection is increased because of the developing countries because of the malnutrition and low
Absolutely.
socio-economic status, sir. So next question to
Absolutely.
Pawan. Generally, how soon the child is brought to a pediatrician in your experience and normal?
Especially, sir, fortunately, this season because of H1N1, the fevers are very high. The children are getting like, not less than 103, 104 fevers, and the child is very cranky, irritable, and not able to feed properly. So that is what bringing the parents to the doctor very soon. Within 24 to 48 hours only, nowadays we are seeing the kids are coming. Now they are not waiting because the fevers the children are getting, they have never seen like 104 degree like that. So these people are getting, they're getting very fast. But especially less than 1 year, this is very important to bring them much early so that we can start our preemptive therapy as early as possible. So that will we can see because in the cities like yes, they are not really waiting because they are seeing the high fevers, so they are coming early only, sir. Today.
Yeah. Still,
But
mother is the best
Dr.
doctor for
Pawan,
the mother is the
Yes, sir.
best doctor for the infections. So she try for paracetamol, giving paracetamol for the child. After 2 days, 3 days, commonly we see the scenario, but it's different now in because of the media and print
Yeah,
and
a lot of awareness is there.
awareness.
Yes.
They are bringing the children early to the pediatrician. That's a nice. So the next question to Sungoj Bhaskar sir: should Oseltamivir be started empirically or after investigations?
straightforward answer to this is once you suspect it is a flu infection, do not hesitate to start Oseltamivir and do not delay it even by 1 hour. Start it empirically and wait for the reports later on. So why we are telling this is this oseltamivir is reducing the complications, severity, and as well the hospital stay by using this early administration of oseltamivir, particularly in these influenza viral infections. A retrospective medical chart review of 442 patients was conducted, and the median time from symptom onset to oseltamivir administration was not less than 48 hours, but average 5 days. And they were divided into four groups based on the time of oseltamivir administration, less than 2 days, 3 to 7 days, 8 to 14 days, and even beyond 14 days. In all these cases, earlier the outcome was very good. Even if you start later, it has still some beneficial effects. So the probability of severe pneumonia and the probability of any severity pneumonia, the conclusion is again the same. Earlier initiation of Oseltamivir administration after symptom onset reduces the complications, severity, and hospital stay by using neuraminidase inhibitor like Oseltamivir.
Yes, sir. Thank you, sir. So the next question to Pawan. What are the factors on which clinical response to oseltamivir depends?
It depends upon various factors like timing of the treatment, patient age, influenza type, like it is A or B, and underlying health conditions of the children, and the vaccination status also will have a very good influence on the response to oseltamivir, sir. So the vaccination history can impact the duration of illness and also the viral shedding. So that way, this even giving this much early is very important. Early suspicion and early initiation of antiviral therapy should be the key, and it should be done within 48 hours of symptom onset for effective optimum effectiveness, reduction in the duration of the clinical illness, and also the viral shedding, because that will also prevent it spread to the other people. So any child with suspected flu, especially in the season when every child is getting flu and the confirmed case that is very rampant everywhere in the city, don't think other options first. And the immune status of the child is also very, very important. Underlying immunodeficiency states, like you have very nicely pointed out, sir, malnutrition is the biggest enemy still humanity is really posing. And the chronic infections like tuberculosis, HIV, steroid therapy in case of our nephrotic syndrome and all, malignancy, anti-malignancy therapy, chronic lung and heart diseases. So these children should be given a priority, and especially in these children, especially the renal dosaging, also renal impairment children, we need to adjust the dose, and also that should be given. So the clinical response depends upon so many factors, sir. So we need to really look into that.
Yeah, great. Pawan. And next question, Sungoj Bhaskar, sir. Generally, how long should oseltamivir be administered? Actually, the graph is, the table was there, everything, but it's only a brushing like thing. Please, sir, Sungoj Bhaskar, sir.
Right. Actually, we already discussed about this thoroughly. However, those who had joined recently, for them, it would be useful. So, oseltamivir is administered on a therapeutic basis and as well on prophylactic basis. Therapeutic for children, it's always 0.3, 3 mg per kg in 2 divided doses per day for 5 days, twice a day. And whereas if you want to give it prophylactically as a chemoprophylaxis, again 3 mg per kg per day, but once a day, not twice a day. So
Yes.
this is the only difference. For prophylaxis, it's once a day. For therapeutic purposes, it is twice a day, 3 mg per kg per dose.
Yes, yes, sir. So prophylactic it should be given for 10 days, sir. And empirically, if we start for the infective cases,
Yes.
we have to give twice a day for 5 days, sir. So great answer, sir. And next question into Pawan. Do you prescribe antibiotics concurrently? Because the guideline says should it be used that much concurrently? But when you want to use these cases, please, Pawan.
This is very important point, sir, because distinguishing viral from bacterial infections is crucial to guide our antibiotic policy and antibiotic therapy. And we definitely, antibiotics are not typically prescribed for flu management in OPDs, and even in the admitted children, unless there is a sign of secondary bacterial infection in terms of like pneumonia, sinusitis, and otitis media. So we all know that flu is a viral infection, and antibiotics are ineffective against the viruses. And overuse of antibiotics also can lead to antibiotic resistance. We ran campaigns against, rational use of antibiotics, Rapstar campaign and all. So especially we need to be little careful in reading the reports, like especially CBP and how to differentiate a viral from bacterial infection. CRP helps there. CBP with the neutrophil, neutropenia and lymphocytosis will help there. So that will guide us whether to start an antibiotic so immediately or not. If the child is really sick and is very sick and child is admitted, definitely there is no problem in starting the prophylactic antibiotic in as per the guidelines of IMNCI, and hospital policy also should be considered there.
Yes, sir. So the important thing is here the concurrent use of antibiotic. The child is having complications, as you earlier said, otitis media and SARI. and all the things, if the pneumonitis and otitis. So we have to use the antibiotic concurrently, and also we have to think of any secondary bacterial infections adding to this. So nothing. The first antibiotic which has to be chosen is amoxicillin, as earlier said. So next question to Sungoj Bhaskar sir. How is oseltamivir tolerated, and any major side effect, adverse effects for the oseltamivir, sir?
Yeah, I have personal experience of more than 5 years with Oseltamivir. We do extensively use it in our inpatients, and major adverse effects until now we didn't see them except for minor side effects like nausea, sometimes vomiting. But major adverse effects we did not see them. But we need to keep them in our mind, like some serious skin reactions, like you can say Steven Johnson, or even TEN, that is a toxic epidermal necrolysis. These side effects are seen. That's what it's reported in some cases somewhere, but when they are very rare. And thirdly, we need to think in terms of renal function as well. Since this drug is excreted through kidneys, if there is any AKI, acute kidney injury, or kidney issues, we may have to titrate the dose. Otherwise, a well-tolerated drug can be used.
Yes, sir. Thank you, sir. Next question to Pawan. Any contraindications or precautions to use of oseltamivir?
So usually oseltamivir by drug is generally very well tolerated in children, but there are some contraindications like hypersensitivity to the drug or any component of the product that should be kept in mind. And second thing is renal impairment. There should be some dose adjustment may be necessary for children with renal impairment. As sir has clearly told, it will be excreted through kidneys, so it should be taken care. And sometimes, oseltamivir may increase the risk of seizures in some patients. That is what mentioned in some literature.
Yes.
And the precautions, especially, are oseltamivir is approved in children 1 year and above. So this is what we need to understand. And safety and efficacy in younger infants are being studied now. And pregnancy and lactation, especially, the precaution should be it's a type C drug. It's a category C drug for pregnancy and lactation, where we need to outweigh the benefits with the risk. So that is where we need to see. And there are some monitoring of neuropsychiatric symptoms also we need to be taking care. There are two drugs here we can mention there, like probenecid and dichlorphenamide. So it can increase the risk of side effects of this oseltamivir. So that is what we need to keep in mind when you are prescribing the drug of oseltamivir.
That's good. So mostly it's the safest drug,
Safest
oseltamivir.
drug.
We can choose
Yes.
and give it to the patient as early as possible. And so
Safety
summary
profile is well established, and it is a very
Yes.
proven efficacy with a very good safety profile.
Yes. So finally, the summary is proper diagnosis and early treatment can prevent flu complications, and empiric use of oseltamivir reduce lower respiratory complications, hospitalizations, and antibiotic use. And WHO and American Thoracic Society and Ministry of Health and Family Welfare recommends empiric use of oseltamivir. So thank you so much for my panelists. And thanks to Prashant, Nagadevi, and Samriti, who had made this webinar. So really, it is useful, and the need of the topic is. So I close my session with these few words. Thank you, Heterodrugs.
Excellent
sir.
moderation, sir. Excellent moderation,
Thank
Dr.
you.
Sridhar, sir. And Sunkoj, sir, I learned very nice points from you, the practical points. Thank you so much, Sunkoj Bhaskar, sir.
Yeah, I'm sure the
Thank you, Dr. Pawan.
participating audience would share their opinion. I'm sure the doctors would also have liked it and learned a lot from the insights. Thanks, Dr. Sridhar. Thanks, Dr. Pawan. Thanks, Dr. Sankoch. It was a lovely
Thank you.
webinar giving